Masoodi, and he will present inflammatory bowel disease registry, step starts, Crohn's disease, colitis or Crohn's colitis foundations in Saudi Arabia.
Thank you very much. Nahmadu wa nasalli ala Rasulil Kareem. At the outset, I am highly grateful to the organizers for giving me this opportunity to present my paper. As all of us know that IBD are among the leading causes of financial burden, morbidity and employee absenteeism in developed countries because of their chronic remitting and relapsing courses. It's estimated to affect the Canadian economy to the tune of $100 million per year. And unfortunately, IBD, inflammatory bowel disease, Crohn's disease, as well as ulcerative colitis affects the patients in their productive years. These patients, their parents, spouses need a lot of moral support. We know that we cannot prevent inflammatory bowel disease because we don't know what's the exact etiology, but we can prevent the complications as colorectal carcinoma or fistulization in Crohn's disease if we pick the disease early and give a unified treatment in order to take care of these complications. Just a worldwide data, 1 million cases of all ages have been found to be in Europe and more than 1.5 million in US. In India, it is 44 per 1 million, and we don't have an epidemiological study in Saudi Arabia, so I am sorry to say, probably we don't have a register. We don't report the cases, and probably some patients don't seek their medical attention. One study quoted that 40% of the patients in Australia, they were using alternative medication, and we don't know what will be the percentage in Saudi Arabia. There are a lot of factors in Saudi Arabia. One is the cultural factor, religious restrictions. For example, rectal bleeding is often said that it is a hemorrhoidal bleed. And probably one of the factors is that we lack female colonoscopists. Colonoscopy is, after all, a harassing test, and especially for a female who has not been exposed and who is cultural, who has a lot of religious restrictions and cultural restrictions. Those patients usually present with metastasis. As we saw in the previous sessions, that a lot of patients present late. Probably one of the factors is that we lack female colonoscopists. And there are taboos associated with rectal bleeding. I came across Dr. Gandhi's study. It's a hospital-based data. They found 77 patients of Crohn's disease, and 13% were in the first 10 years. Mean age, again, 25 to 11, plus minus 11. That means a productive age. And both small and large bowel are affected in 78% of the patients. They found that most of the patients had poor compliance to the medication. That 5 patients in Crohn's disease, they ended up with fistulization, giving it a rate of 6.5. And surgery was needed in 12% of the patients. Another study, Dr. Fada's study, I came across, is again a hospital-based data. As I mentioned that we lack epidemiological data about IBD in Saudi Arabia. This study also confirmed that the patients are affected in their prime youth. The authors concluded in this study that IBD has increased over these years, and it is no more uncommon. It is as common as in the West. So what is the need to answer all these questions? The need is that we need a Crohn's and Colitis Foundation of Saudi Arabia, who will address, as we were discussing, when to screen, what to do, who will be responsible. We need a society which will answer these questions, which will follow these questions. Such societies already exist in Canada, in the United States, and in India as well. So what will be the aims of this Crohn's Colitis Foundation of Saudi Arabia? First of all, as it was mentioned, that awareness of IBD in the community. Let the patient come before fistulization. Let the patient come before ulcerative colitis terminates into the metastasis, into the colorectal carcinoma. And we need rehabilitation of these patients. These patients are affected in their prime age, and it's a chronic remitting course. Once he develops a disease, he doesn't get rid of it. And there we need training programs and, of course, research. So what I propose is that we need 3-step program. First of all, we need to register all gastroenterologists, internists, their emails, addresses, who are ready to help in this. And second, that all diagnosed patients need to be followed up in a methodical and on a careful basis. And third thing, most important thing that an awareness has to be generated in the public and special training programs have to be organized. We need to evaluate all ulcerative colitis based on clinical, endoscopic and histological. Because of the time limiting, I am not going to elaborate on these, but there's a well-defined that a patient has to have a pathological diagnosis. It has to have a chronicity score, activity score by a gastropathologist, because a lot of disease mimic. I have seen in Saudi Arabia a lot of patients getting a label of IBD and getting treatment unnecessarily. So we need to be reconfirmed by a gastrohistologist. There has to be a complete coordination. We cannot send all patients to Jeddah, to Riyadh. We need to have a system so that a telemedicine communication between a primary care physician and a tertiary care. And research has to be started on this effect to develop the local data. What are the factors? We cannot depend ultimately on the West. What is their data? Our genetics is different. Our factors are altogether different. So local data has to be generated. We need to pay special attention towards childhood and adolescence, because 25% of the patients present in adolescence, they have growth abnormalities. We need an endocrinologist involvement. We need a pediatrician involvement. And exacerbation is known to found in pregnancy. So we need a health education that if, for example, a patient has exacerbation at the time of conception, the lady is going to have a worse story of her ulcerative colitis. And we need to have awareness that azathioprine is a safe drug in pregnancy. We need to have that the patient has to continue the treatment. And my surgical colleagues will agree with me that there will be a need of colostomy clinics and other post-operative health education as well. Most important, what I feel that health education and training programs, we need that a red alert be for a bleeding PR, removal of taboos and IBD helpline. We need workshops, national as well as at an international level, and an IBD desk, a quarterly journal for the professionals, and health education for patients, emphasis to avoid indigenous drugs for bleeding PR. These patients need a lot of support, emotional support. We can develop a web help that I'm happily living with the IBD, and IBD Day can be celebrated to generate all awareness in the masses.
2 minutes, please.
Yeah, I'll conclude. The research can be epidemiological and genetic to look into the factors here. And as all of us know that resource development for this foundation will be very important. We could take monthly donations from employees, from business, and last but not the least, IBD Act needs to be formulated. To summarize, Mr. Chairman, I would like to say that Crohn's and Colitis Foundation shall upgrade IBD patient care by ensuring proper diagnosis, registry and follow-up. Health education can be boosted up in the country, and a coordination between primary care and tertiary care physician can be achieved by this foundation. And we need that research at all levels to be generated and local data created, and to take care of the complications and management of the inflammatory bowel disease patients. Thank you so much.